Olá, boa tarde.
Hello, good afternoon. Be very much welcome. Now we'll move on to the Breastmit. We'll continue with the session. Dr. Carolina.
Doutora em.
She has a PhD, Dr. Carolina. I can't hear him. The microphone is very low. His microphone is very low. I really can't hear him. I apologize for that. Não estou ouvindo ele. O microfone está muito baixo.
Espero. Vou
Well, I
repetir o que
hope
está
I will
acontecendo, né?
repeat. Now it seems that you couldn't hear me. Now they can hear
Boa
me.
tarde.
Well, so let's move on to the afternoon session. Let's
Escalonamento.
see who's going to. Dr. Carolina Valadares will lead this panel discussion
Especializada
on
em técnicas de escalonamento
downscaling.
minimamente invasivo.
She is an expert in minimally invasive technique and author of retrospective studies
Escalonamento
with
perfeito.
selection criteria for percutaneous downscaling.
Boa tarde a todos.
Good afternoon, everyone. I thank you very much for the invitation, Henrique, to be here with you, participating on such an enlightening panel with experts from all over the world in downscaling. It is an honor. Now we'll introduce the speakers of the next talks. We'll have 4 talks this afternoon. First speaker is Dr. Frederieke van Duijnhoven, oncology surgeon of the Netherlands Cancer Institute, specialized in breast cancer and thyroid. Her study is concentrated in a downscaling local treatment in patients that underwent neoadjuvant treatment, as well as in patients that are under treatment of ductal serous. She's the co-author of important studies such as MICRA and LORD, and today she is the AORT secretary. We will also have Dr. Shelley Hwang, the head surgeon of the UCSF Ellen Healy Family Cancer Center from the University of California. She is the head of the Oncology Surgery Division of the University of California in San Francisco, and she is the senior researcher of the General Hospital in Singapore. We will also have the talk from Dr. Holmes, who is a surgeon, breast surgeon from California, the California Medical Center, and he is also an affectionate for downscaling treatment, and he has a number of publications, over 50 publications in breast cancer. And finally, we'll have Dr. Stuart McIntosh, last but not least, who's also a cancer surgeon. He is a full professor of the Queen's University Belfast. And in addition, he is the head researcher of the small trial. So we will have excellent presentations now. I yield the floor to our speakers.
Hello, everybody. My name is Frederieke van Duijnhoven. I'm a breast cancer surgeon at the NKI in Amsterdam in the Netherlands, and I'm very happy about being invited to present on our LORD patient preference trial regarding patients with ductal carcinoma in situ. I don't have any disclosures, and I'm part of a very big team, all listed here. So what I wanted to discuss today is, of course, the aspect of DCIS as a low-risk lesion, and then present to you some data about our patient preference trial, which was originally started as a randomized clinical trial, the LORD trial. So low-risk DCIS, so what is it, and which clinical trials are concerned with this patient group? Ductal carcinoma in situ is mostly detected by screening mammographies as a calcification on mammography. It is, however, always intensively treated, be it with surgery, plus or minus radiotherapy, and in some cases even with hormonal therapy. And since the implementation of the National Breast Cancer Screening Program, the incidence of DCIS has increased considerably, which is reflected in the pink bars here. And of course, one would expect that concurrently, the incidence of higher stage breast cancer would decrease if you would consider DCIS to be a precursor for breast cancer. Unfortunately, this is not the case, as is indicated here. You see that the incidence of DCAS has increased because we detected with the national screening programs, but at the same time, the incidence of stage 2, 3, and 4 breast cancer has not decreased. So we can only assume that part of the DCAS that we find in the national screening program never develops into breast cancer. The problem is, of course, is to identify which DCAS remains in situ and which DCAS lesions would progress to breast cancer. Well, we have some help from this excellent study by Mark Reiser, which concerns a large SEER data analysis of patients with DCIS who did not receive any local regional therapy. So over 2,200, it's over 1,200 patients were included with a median age of 60 years. And what he showed was that the ipsilateral invasive breast cancer rate was only 12% after 10 years. And if you further diversify into DCS grade 1 to 2 versus grade 3, then the risk of ipsilateral invasive breast cancer for grade 1 and 2 DCS is only 12.2%. So only about 1 in 8 DCS patients actually develop breast cancer. He then further subdivided the patients in lowest risk groups, which included patients with an age over 40 years with grade 1 and 2 breast cancer that was hormone receptor positive. And for these patients, the risk of ipsilateral breast cancer was only 5.9% after 7.5 years. So for this very low risk group, only about 1 in 15 patients develop invasive breast cancer. So in answer to the question, what's low risk DIS? It would be DCIS grade 1 and 2, which is hormone receptor positive and occurs in patients over 40 years. This is the basis for several clinical trials that collaborated in the Precision Project, which was funded by the Grand Challenge UK, and for which these excellent colleagues are the main project leaders. So 3 clinical trials in the Precision Project, one in the UK, one in the US, and our Dutch trial in Europe, for which Professor Dr. Jelle Wesseling is the project leader. Trials are listed and compared here. In red, you see the differences between the 3 trials, which concern some small difference in age and eligibility based on the hormone receptor status, which has to be positive for estrogen in the LORD in a common trial, and for which in the LORD trial there were no restrictions. So as for the LORD trial, as mentioned, Jelle Wesseling, the project leader, it was originally designed and started as a randomized clinical trial for patients with grade 1 or 2 DCIS, about 1,200 patients to be included, randomization between active surveillance, so no local treatment, and standard treatment with surgery, with or without radiotherapy. The primary outcome was the percentage of patients without ipsilateral invasive breast cancer at 10 years follow-up. Inclusion criteria included patients over 45 years of age, any size of DCIS, DCIS grade 1 or 2, obviously, and as mentioned, hormone receptor positive and HER2 negative patients. So no signs of invasive disease, such as a palpable mass or density on mammography. So we started quite enthusiastically in 2015, hoping to include many patients, but then after 2 years, we had included only 73 patients. Not what we hoped for and not what we expected, of course, but it turned out that out of every 8 women that were asked for the trial, 7 did not want to participate because they did not want to be randomized. And even out of the 73 who did want to participate, 12 of them refused the arm that they were allocated in. So that led us, of course, to question, did we pick the right design? Is a randomized clinical trial the optimal design in such a de-escalation study? And maybe a patient preference trial would be a feasible and realistic alternative. What we did do was ask patients who did not want to be randomized if we could follow up on their um, if we could include them for follow-up in the control DCAS study, which we did in 2019. And what we could then do was two things. We wanted to assess the reasons for our dismal accrual. So we wanted to ask patients, why did you want to participate for the patients in the LORD trial, and for the patients that were in the control DCAS study, we wanted to ask, why did you not want to participate in the randomized setting? And at the same time, we wanted to, of course, to explore the possibility of converting to a non-randomized trial and what would be the statistical consequences. Well, as for the assessment of the willingness of patients to be randomized, we were able to include 68 patients from both the LORD clinical trial and the control DCS trial who returned the questionnaire, so a little over 30 patients in each cohort. What did we find? Well, I guess it's not surprising, but the patients who did want to participate in the randomized setting said that they wanted to do so because of altruism and the chance to de-escalate treatment when randomized in their arm of preference. Whereas, of course, the patients who opted not to be randomized indicated that they didn't want to participate because they had a very strong preference for the active surveillance arm, or they wanted to avoid radiotherapy. So also a de-escalation decision, and they preferred autonomy when making decisions regarding their health. As for the statistical consideration, well, for those of you interested in next level statistics, you can find the numbers here, but it boiled down to an increased accrual of 2,500 patients, of which we expect a dropout of 25% due to hormone receptor status. So at least 2,000 patients need to be included if we change to a patient preference trial. We didn't really have a choice because otherwise the trial would die with less than 100 patients included. So we did decide to continue with the patient preference design. We did so in 2020 and were able to open the majority of the large Dutch breast cancer centers. We performed central immunohistochemistry for assessment of receptor status. So this is the current design. Primary outcome is unchanged, but now we have to include over 2,000 patients, and patients decide whether or not to go for active surveillance or for standard treatment. So this is what happened over the years. We started with these inclusion criteria, and patients entered the randomized trial, and when declining randomization were included in the control DCAS study until early 2020. And later on, from 2020 onwards, patients were included in the preference trial, and at the same time, there was an additional inclusion criteria regarding hormone receptor status. So what happened afterwards? Well, the way to compare this was to ask the National Cancer Registry to supply us with data on the number of women that were diagnosed in the Netherlands between 2020, just before we implemented the preference design, and 2022. We were able to retrieve all data for patients over 45 years who were diagnosed with DCAS grade 1 and 2. So in 2020, when there was still a randomized setting, only 15% of all patients with grade 1 or 2 DCIS in the Netherlands were included. And when we changed to the patient preference design, this increased to 56% out of all patients in the Netherlands diagnosed with grade 1 or 2 DCS. Of course, we were very happy about this result, and of note, the NKR, the National Cancer Register data, they do not take into account the fact that there are also patients there that would normally not be included in the study because of exclusion criteria such as hormone receptor status or mammographic findings. So we can safely assume that the 56% is even an underestimation of the rate of patients that are participating in the trial. This is, of course, reflected in the accrual, which increased enormously since 2020 following the patient preference design. And currently we have over 1,000 patients registered. The expected dropout of 25% due to the receptor status, but it means that we will be able to finish accrual by the end of January 2027. And also not a surprise, but the majority of the patients who enter the trial opt for a watchful waiting strategy rather than the standard treatment with surgery. I think that we can see this reflected in other studies that have assessed the willingness of patients to enter clinical trials and the reasons for either to participate or not participate in randomized settings, because studies have shown that the most important factor to participate in clinical trials is altruism for many of the patients, whereas when they refuse participation in a randomized setting, it's because, well, one can only imagine that patients have a preference for either of the treatment arms, and they dislike the idea of randomization. So when we compare the two designs, a randomized clinical trial versus a patient preference trial, well, the pros for a randomized setting, of course, is the minimization of bias, the maximal causal inference, because you can correct, of course, for the confounders that will be comparable in the randomized arms, and you have a very strict specification of the eligibility, the start of the follow-up for each participant, and the treatment assignment. In a patient preference design, on the other hand, you do reflect clinical practice, you boost accrual, you assess real-world effectiveness, and in the age of shared decision making, this is, of course, much more realistic. Statistics are a bit more complicated, but costs are much lower than in the randomized setting. And again, the accrual will be much, much better, as we've seen, fortunately, in the LORD trial. So in conclusion, I would say that when you want to assess de-escalation for a low-risk disease, such as DCIS, and assess a low-cost intervention, I would say that a patient preference design is actually preferable. So with that, I conclude my presentation, and I thank you very much for your attention.
Hello, everyone. My name is Shelley Hwang, and I'd like to thank Enrique and the conference organizers for the kind invitation to come speak with you today. I'll talk to you about the oncologic safety of active surveillance for low-risk DCIS, which has been a topic that I've been very interested in for many years. I want to just quickly go over my disclosures. I have some grant support, and I'm on the Speakers Bureau for a couple of companies. And just by way of introduction, I live in North Carolina, and I'm sorry that I can't be with you today, but we are on the East Coast of the United States, kind of right in the middle of the country, and we're known for many things, including the beautiful fall weather. So although I can't be with you today, I bring you greetings from our state. So let's first talk about what DCIS is. As many of you know, DCIS stands for ductal carcinoma in situ, which is a precancer, also known as pre-invasive cancer. The estimated incidence of DCIS in the United States is over 60,000 new cases annually. And DCIS now makes up about 20% of all mammographically detected breast cancers. What's really interesting is that if you look at autopsy series of women who died of causes other than breast cancer, about 10% of women harbor DCIS in their breasts, and they're completely asymptomatic. The most important thing I'm going to tell you about DCIS is that it's something called a non-obligate precursor of invasive cancer. So not all DCIS becomes invasive cancer, but some do. And the rate and the likelihood of progression to invasive cancer is unknown. What I do know is that the incidence of DCIS exactly parallels the number of mammogram machines. So if you look at the number of mammogram machines in the United States and the incidence of DCIS, the curves are almost entirely parallel, making getting a mammogram one of the highest risk factors of being diagnosed with DCIS. And DCIS is therefore an unintended consequence of increased breast cancer screening. The intention of mammographic screening was not to detect more DCIS, but this is really what has happened. And now DCIS is about 5 to 7 times more prevalent than before mammogram screening was introduced. So let's start from the basics about why we treat DCIS. And the main reason is to prevent mortality and morbidity from subsequent invasive cancer. We don't do it to treat any symptoms because by and large, patients with DCIS are completely asymptomatic with very few exceptions. So today I'm going to talk to you about how much surgery is enough, and then when no surgery might be enough for some patients. So starting with how much surgery is enough, when you look at the treatment patterns for DCIS, and this is looking at a national registry, we published this several years back, and we looked at the SEER national database of women diagnosed with DCIS from 1991 to 2010. And what was clear from this paper is that the majority of women who are diagnosed with DCIS in the United States undergo lumpectomy with radiation. And I think that's probably true in your country as well. The other things you can note is that the incidence of unilateral mastectomy for treatment of DCIS has gone down. So about 20% of patients with DCIS now get a unilateral mastectomy. But what is also very important to note is that the bilateral mastectomy rate here with the dotted lines on the right has actually gone up. And in some series, about 10% of all women who are diagnosed with DCIS undergo a bilateral mastectomy. Now, that's even more important in women who are young and diagnosed with DCIS. When you look at a cancer registry called the NCDB of women diagnosed between 2004 and 2016, when we look at women who are under the age of 50 when they're diagnosed, the use of bilateral mastectomy is almost 30% in these women. But if women are less than 40 years of age when they're diagnosed, the bilateral mastectomy rate can be as high as 50%. So even though DCIS is not symptomatic and its risk for invasive cancer is unknown, the downside of treatment is pretty significant in those women who undergo bilateral mastectomy for this disease. So let's talk a little bit about lumpectomy because the majority of patients undergo lumpectomy for this disease. And I'm showing you a slide of DCIS, and the DCIS is coming right up to the edge of the margin. So how much of a margin is enough in women who are undergoing surgery with breast conservation for DCIS? Well, all of you know that many years back, the SSO guidelines for invasive cancer established that margins wider than no ink on tumor are not indicated for invasive cancer. And a couple of years after that, the SSO Astro guidelines for DCIS show that the minimum margin distance of 2 millimeters has been recommended to reduce the risk of local recurrence in women with DCIS who are undergoing whole breast radiation. And this recommendation has been endorsed by SSO in the United States, as well as other professional societies. I just wanted to bring to your attention that our group also recently published a paper that was published last week, actually, in BMJ. And this confirmed that the margins are very important in terms of determining recurrence risk in women who are undergoing breast conservation surgery for DCIS. And on the left panel here, you can show the risk of invasive breast cancer by DCIS margin status. And the blue line here indicates patients who have less than 2 millimeters of margin. And the red line here is greater than 2 millimeters. And you can see that there's a clear, significant difference between women who have greater than 2 millimeter margins and less than 2 millimeter margins. And you can see here on the right panel that the risk of DCIS is also increased based on margin status. What we don't know is that whether 1 millimeter is different from 2 millimeters, and whether 3 millimeters might be different from 2 millimeters. So we're in the midst of doing that study. But what distinguishes this study from the previous guideline recommendations is that we performed a patient-level analysis and confirmed that margin status is important in patients who are undergoing lumpectomy for DCIS. Now, the guidelines that I told you about of 2 millimeters for a lumpectomy in DCIS applies mostly to patients who had lumpectomy and radiation. But in some situations, these guideline recommendations may be less applicable, and that includes patients who are undergoing partial breast radiation, who are undergoing lumpectomy without radiation, women with very large DCIS, those who have unfavorable genetic predisposition to cancer, so ERCA mutation carriers and those with other genetic mutations, for instance, women with multifocal DCIS, and women who are very young at the age that they're diagnosed. So these patients were underrepresented in the data that was used to develop the guideline recommendations. And other relevant factors also need to be taken into account, such as the size of the breast, the location of the close margin, is it on the skin or the chest wall, or was the lumpectomy performed in combination with an oncoplastic procedure where it might be much more difficult to go back and take additional margin for DCIS. So obviously this needs to be taken on a case-by-case basis, but for most patients who are undergoing lumpectomy for DCIS, the current margin recommendation is indeed 2 millimeters. Now, what happens to patients who undergo lumpectomy with no radiation? I told you earlier that most patients with lumpectomy for DCIS undergo radiation, but if you don't undergo radiation, what would the recurrence risks be? And this was a very nice study performed in the United States, ECOG 5194, and this looked at two groups of patients who underwent lumpectomy alone for DCIS. Cohort 1 was a group of patients who had low to intermediate risk DCIS, and cohort 2 was a group of patients with small but high risk DCIS. And you can see that the recurrence and all these patients had margins that were at least 3 millimeters in size. So grade matters, because if you look at patients with high grade disease, even though most of these patients had very small DCIS, the incidence of ipsilateral recurrence, so recurrence in that breast at 12 years, was about 25%. And the risk of invasive cancer was about 12 to 15%. In the lowest risk group, the risk continues to go up, but the lowest risk group had about a 12% risk of breast recurrence at 12 years, and less than 10% of that was invasive cancer. So for low-risk DCIS, the recurrence risk after lumpectomy alone without radiation is only about 1% per year, which is similar to the risk you may see in patients with ADH. Now, the outcomes of excision alone for DCIS have been studied in multiple different studies. So the ECOG study, I showed you the numbers in the previous slide. There was a single institution study by investigators at Dana-Farber who showed that at 5 years, the local regional recurrence rate was 12% with excision alone. And the other studies here show that there definitely is an increased risk of local recurrence with excision alone. But for patients who are at low risk, for patients who are elderly or who are not good candidates for additional radiation, lumpectomy still is a reasonable option in that setting. And there's been a recent interest in performing nipple-sparing mastectomies for DCIS. And in a couple of studies now, nipple-sparing mastectomies have been shown to be quite safe with a local regional recurrence rate of less than 5%. So this is a very safe and nice procedure for patients who are undergoing mastectomy for DCIS, as long as the nipple is not involved. And so here I show you some local regional recurrence rates. These are patients who underwent mastectomy and skin-sparing mastectomy for DCIS. And if you look at those patients, they have a very similar local regional recurrence risk to patients who are undergoing nipple-sparing mastectomy. Now, what about the contralateral risk for breast events? The 30-year contralateral risk was recently published, and it shows that that risk is quite low. And so for most patients, they are able to have a very low risk of contralateral breast disease, and so it's generally not recommended in patients who are not at elevated risk for breast cancer. In terms of sentinel lymph node biopsy, this is not currently recommended. There was a large series of patients who had an initial diagnosis of DCIS and underwent sentinel lymph node biopsy at MD Anderson. And the sentinel lymph node biopsy positivity was only found in 2.4%. So this is generally not routinely recommended and only recommended if patients have upstaging at the time of initial surgery. So in the last few minutes of the talk, I'm going to talk to you a little bit about when no surgery is enough. And the reason that this is an issue is when you look at the increased incidence of DCIS here on this panel, and you compare it to the risk of invasive cancer, even though we've been diagnosing and treating DCIS, that has not brought about an associated reduction in the risk of invasive cancer. So there's been a lot of discussion about whether we might not be removing the lesion that's at highest risk for developing invasive cancer. And when you look at the outcomes of patients who have been diagnosed and treated for DCIS, and you look at breast cancer specific survival, there's no difference in patients who undergo mastectomy, lumpectomy with radiation, and lumpectomy without radiation. And this has been tested in patients who have low-risk prostate cancer. This was the PROTECT trial, which compared active surveillance to surgery plus or minus radiation therapy. And in 1,600 men, there was only 17 deaths from prostate cancer, and there was no difference in this low-risk population, whether patients had surgery, radiotherapy, or active monitoring. Now, we look to see what the risk of invasive cancer would be in these patients who had low-risk DCIS. So if we took all groups of patients with DCIS, at 20 years, there's about a 20% risk of having invasive cancer. That seems to be dependent on grade, as well as ER positivity. And the blue mark here is patients who have high-risk DCIS. But if you look at the lowest risk patients who are ER/PR positive in grade 1 to 2, you can see the risk for invasive cancer in these patients is quite low, less than 10% at 10 years. So active surveillance trials for low-risk DCIS, the previous speaker spoke to you a little bit about the LORD trial, are looking at newly diagnosed low-risk DCIS, looking at ipsilateral invasive cancer-free survival, comparing patients who undergo surgery versus active monitoring and are followed by annual or bilateral or biannual mammography. Of course, if patients develop cancer during follow-up, there is intervention and surgery for those patients. So this is the team who's helped to put together the COMET study, which takes patients who are newly diagnosed with low-risk cancer or low-risk DCIS, and we randomize them to either getting surgery or getting active surveillance. And both of these groups can have endocrine therapy if they choose to. And we are going to be looking at patients in terms of invasive cancer diagnosis, as well as patient-reported outcomes, looking at fear of cancer recurrence, body image, and anxiety. So the study completed accrual in January of this year. And I just wanted to bring your attention to our website, which has information about the study for you and patients who may be interested. And the summary of active surveillance trials for low-risk DCIS globally is the LORIS trial, which is a trial in the UK looking at low-risk DCIS, the COMET trial, which I explained to you before, the LORD trial, which was presented to you by the previous speaker, and the LORETA trial in Japan, which is looking at a single-arm study of low-risk DCIS treated with tamoxifen alone. So in summary, surgery remains the mainstay of therapy for DCIS, and it yields excellent oncologic outcomes. Indications for lumpectomy, nipple-sparing mastectomy, contralateral mastectomy, and sentinel lymph node biopsy are supported by some evidence, and these treatment recommendations should be carefully individualized according to the patient. I talked to you a little bit about some trials that are in progress internationally to determine whether the lowest risk DCIS can be managed without surgery, as we do in other high-risk situations such as LCIS and ADH. And the generally excellent prognosis in low-risk DCIS is an opportunity for us to right-size the treatment using increased surgery and adjuvant therapy for those at highest risk and de-escalation of surgery for those at lowest risk of invasive progression. So I'd like to thank the people who do all this work, and I very much appreciate their collaboration. And I'd like to thank you and the conference organizers for your attention, and I wish you a very successful meeting. Thank you very much.
It's a privilege to participate in the 4th International Symposium on Minimal Treatment and Breast Imaging. I'm Dennis Holmes. I'm a breast cancer surgeon and clinical researcher with 20 years experience in breast tumor ablation, including 15 years experience in breast cancer cryoablation. The topic that I presented to you today, that I will present today, will focus on breast cancer cryoablation in the multidisciplinary setting with the goal of providing practical guidelines for patients and physicians. This is a topic that I recently wrote about and published in a medical journal article, which you can find online by searching for the article by name or simply downloading it directly from my website, which is shown here. This article addresses many of the issues that I have encountered in the 20 years of experience performing cryoablation. It also discusses many of the issues that radiologists, medical oncologists, and radiation oncologists encounter in caring for breast cancer cryoablation patients. So first, what is breast cancer cryoablation? Breast cancer cryoablation is a minimally invasive procedure that uses extremely cold temperatures to kill cancer cells. Over the last 15 years, cryoablation has emerged as a minimally invasive alternative to breast cancer surgery for treating patients with early-stage breast cancer. The main goal of cryoablation is the destruction of a breast cancer along with a surrounding margin of normal breast tissue, which is comparable to what we aim to achieve with lumpectomy. With cryoablation, our goal is to ablate the cancer, shown here in red, with a surrounding 5 to 10 millimeter margin, using a roughly 4 by 3 by 3 centimeter zone of necrosis or ablation zone, which is the actual volume that is killed by the ablation procedure. And this is accomplished by creating a 5 by 4 by 4 centimeter ice ball, shown here in blue. And this is accomplished using liquid nitrogen or argon gas, which circulates within the cryoprobe to freeze the core of the cancer to about 185 to about minus 185 degrees Celsius. Just as with lumpectomy, cryoablation may be followed by anti-cancer medications or radiation, depending upon the circumstances. Several potential advantages make cryoablation an appealing alternative to lumpectomy. For example, cryoablation expands the breast cancer treatment options for patients seeking to avoid traditional surgery because of philosophical reasons, competing health concerns, or other reasons. As an office-based procedure performed using local anesthetic, cryoablation minimizes or eliminates most of the potential side effects of breast cancer surgery and general anesthesia. Compared to breast cancer surgery, cryoablation has minimal impact on quality of life, and it also permits early return to work and to daily activities. So with all that good news about cryoablation, what's the evidence that it actually works? First of all, you should understand that there are currently no published randomized controlled trials or other trials that directly compare the effectiveness or safety of cryoablation to lumpectomy, which is a gold standard for breast cancer studies. However, this prospective study, the ICE3 trial, that is currently underway, recently published its 3-year interim results. The study enrolled 194 patients aged 60 and older with unifocal ultrasound visible breast cancers. All tumors were invasive ductal cancer, invasive ductal carcinoma, measuring 1.5 centimeters in size, and all were hormone receptor positive and HER2 negative. At the discretion of the patient and their treating physicians, 75% of the patients received endocrine therapy after cryoablation, but only 14% of patients received adjuvant radiation. With 3 years follow-up, the study found a local recurrence rate of only 2%, which is comparable to what we would generally expect from lumpectomy patients, especially with so few women treated with radiotherapy. In addition to the patients treated in the IC trial, there are additional opportunities to use cryoablation in the management of stage 0, 2, 3, and 4 breast cancer. particularly when patient consent or healthcare resources limit the treatment options for a patient. As discussed in this journal article, breast cancer care during a pandemic. I'll repeat this part. In addition to the patients treated in the ICE3 trial, there's additional opportunity to use cryoablation in the management of stage 0, 2, 3, and stage 4 breast cancer, such as when patient consent or healthcare resources limit treatment options. As discussed in this journal article, breast cancer care during a pandemic, an opportune time for cryoablation, there are multiple breast cancer scenarios for which cryoablation might be utilized as a definitive therapy, where a cryoablation of the cancer is performed without a plan for subsequent breast surgery, or as a stopgap measure, which refers to the use of cryoablation as a temporary solution prior to anticipated breast surgery, like when a cancer might be ablated to prevent further growth or spread for a patient while she's still considering whether or not she'll have a lumpectomy or a mastectomy. An important principle in the guideline article is the concept of the accountable provider. Just as with surgery, every cryoablation patient should be cared for by a provider who is accountable for making sure that all aspects of the diagnostic workup, pre-treatment plan, and post-treatment care are addressed in a multidisciplinary context. This begins with making a decision about who will perform the cryoablation procedure, whether it'll be a surgeon or a radiologist. In my opinion, the major advantage of seeking cryoablation from a breast surgeon or a surgical oncologist is that these cancer specialists customarily assume responsibility or accountability for not only ablating the cancer, but also for coordinating all aspects of the initial diagnosis, treatment, and subsequent management of the patient. This begins with bringing a surgeon's mindset to the cryoablation procedure in terms of mapping out the extent of the cancer and planning a cryoablation treatment that places a premium on achieving clear margins. As accountable providers, surgeons routinely determine the proper sequence of cancer care, surgery first or systemic therapy first. They order and interpret genomic testing. They perform and refer patients for genetic counseling and testing. Surgeons routinely order appropriate staging studies. They discuss and perform the surgical alternatives to cryoablation, such as lumpectomy or mastectomy plus or minus reconstruction. They determine the most appropriate management of the lymph nodes and perform lymph node surgery if needed. They refer to or coordinate care with medical oncology, radiation oncology, and functional medicine. And they order follow-up imaging and perform follow-up breast examinations. If a radiologist is unwilling or unable to personally provide this kind of comprehensive care, or has no partner who will provide the care on his or her behalf, there is great concern that the patient's overall cancer care will be significantly compromised. To aid the process of managing patients and to provide patients sort of a guideline for what they should expect, I prepared this checklist of quality metrics that should be considered for all cryoablation patients as part of the initial diagnostic workup, pre-treatment planning, and post-treatment workup. In the time remaining, I'll discuss a few of these quality metrics, beginning with the importance of high-quality mammograms. Although cryoablation is usually performed under ultrasound guidance, patient selection is the most important key to success. To that end, high-quality mammography might reveal additional areas of disease, such as multiple cancers in the same breast, or spiculations, or additional calcifications that are present outside of the dominant mass that could impact whether or not a patient will be offered cryoablation, or might influence how the cryoablation procedure is performed if the surgeon decides to proceed with cryoablation. High-resolution ultrasound is also essential because it might reveal subtle tissue changes that might suggest the presence of more extensive disease, such as these intraductal extensions of tumor beyond the main tumor mass, or peritumor edema beyond the dominant mass, which could suggest that the cancer involves more than just a dark area you see here, but in fact, the entire area that's outlined by the hash marks. When possible, contrast-enhanced MRI should also be considered to exclude multiple cancers, as shown in this image. As you see, there are 2 lesions seen in this breast, not just the one that led to the patient's diagnosis. MRI can also be used to facilitate detection of speculations, shown here emanating from this mass, multifocal cancer, shown here and here, or multicentric disease present in another quadrant of the same breast, or contralateral disease present in the opposite breast. Now let's take a look at some of the treatment approaches. Modern technology for office-based cryoablation is optimized for treatment of a single tumor measuring less than or equal to 2 centimeters, for which cryoablation can be easily performed using a single cryoablation zone of necrosis, measuring generally about 4 by 3 by 3 centimeters. That's the area shown here in blue. Within, again, an ice ball that's generally about 4 by 5 by, that's usually 5 by 4 by 4 centimeters, shown here in yellow. Specifically, the area shown here in yellow, the outer rim of the cryoablation zone, is called the cryoablation zone of inflammation or zone of injury, which is near the surface of the ice ball. And this is an area that is frozen, but it's not frozen at a temperature that's cold enough to be ablative. So it's an area that's injured, but ultimately heals, which means that cancer cells that are present within that area may in fact survive, whereas the cancer cells that are within the blue area would be expected to be fully ablated. For lesions that are greater than 2 centimeters, use of multiple partially overlapping cryoablation zones of necrosis can be utilized to encompass the larger tumor with surrounding surgical margins. Although there's no official manufacturer's guidance on the appropriate spacing between the adjacent cryoablation zones of necrosis, in my judgment, spacing each adjacent cryoprobe insertion 1.5 centimeters apart minimizes to a reasonable degree the risk of leaving incompletely ablated cancer between the overlapping cryoablation zones of necrosis. The final topic that I would discuss is a follow-up of the patient treated with breast cancer cryoablation. Currently, there are no standard post-treatment follow-up protocols for patients treated with breast cancer cryoablation. However, it is reasonable to expect cryoablation patients to undergo annual clinical breast examination and annual mammograms in keeping with the standard protocol for lumpectomy patients. Annual mammograms may be supplemented by ultrasound or contrast-enhanced breast MRI, depending upon the clinical findings, such as the breast density, risk factors, patient preference, or the features of the original cancer. For example, if the cancer presented with calcifications or if it was mammographically occult. Regardless of the regimen, the purpose of the follow-up imaging is to detect residual or recurrent breast cancer, which, if present, is most commonly found along the margins or the perimeter of the cryoablation zone, just as lumpectomy patients generally have recurrences, if they have it, along the margins of the lumpectomy cavity. However, given the difficulty of any of these imaging studies, mammogram, ultrasound, MRI, to exclude the presence of microscopic disease within the cryoablation zone, one might consider performing routine core needle biopsies of the cryoablation site at some point after the cryoablation procedure to document complete tumor ablation. That's a practice that I generally utilize and I recommend for most of my patients, a core needle biopsy of the cryoablation site 6 months post-cryoablation, just to document that there's complete ablation of the mass. Of course, there is a learning curve when it comes to interpreting post-cryoablation imaging studies. Some of the things that radiologists should anticipate on post-ablation mammograms include a thin oval scar that roughly corresponds to the outline of the cryoablation zone of necrosis that is created at the time of cryoablation. That generally disappears with time, and in this patient, 3 years post-cryoablation, you can't really see that, what we call oval rim of scar that you see early on after cryoablation. There's also a tumor ghost, which you see here and here, which is the visible remnant of the dead cancer mass that is initially quite obvious in initial years, in the early years after cryoablation, but gradually disappears over time. And again, in this patient 3 years post, you can barely see the residual mass remaining that corresponds to the cryoablation site. However, the presence of the tumor ghosts could raise concerns that cancer cells still remain at the site, which is another reason why I usually recommend a needle biopsy to eliminate any anxiety for the patient or anxiety for their healthcare providers regarding the possibility of recurrent or residual disease. In general, the biopsies almost always reveal fat necrosis, microscopic fat necrosis, fibrosis, and chronic inflammation. Speaking of fat necrosis, it's also important to recognize that new microcalcifications developing at the cryoablation site might suggest the presence of a recurrence, but most likely indicates the presence of fat necrosis, especially when the calcifications appear soon after the ablation procedure. And sometimes they may be quite prominent, as shown in this patient. This is her breast 6 months post-cryoablation with just 2 areas of fat necrosis, but by 2 years, there were a significant number of fat-related calcifications or fat necrosis-related calcifications that develop that roughly outline the dimensions of the cryoablation zone of necrosis. Although these microcalcifications clearly look like fat necrosis, it might be necessary to perform a needle biopsy of the site to rule out recurrent disease. Despite the routine use of ultrasound to monitor the cryoablation site, the presence of a tumor ghost and the significant tissue distortion that is usually caused by cryoablation can make it very difficult for ultrasound to detect residual or recurrent disease within the interior of the cryoablation site. Although it can be helpful in detecting new masses that may appear at the margins of the cryoablation site, which in fact could represent either recurrent disease or fat necrosis and might require a needle biopsy to determine the difference. Contrast enhanced breast MRI is particularly helpful in detecting the presence of residual disease around the cryoablation site, but just like the other studies, is limited in its ability to rule out the presence of microscopic disease within the cryoablation zone. So here again, there may be a benefit to performing a needle biopsy of the site to document complete ablation. However, it's still very reassuring when a follow-up post-ablation MRI shows absolutely no residual enhancement in the case of a patient who had a very obviously enhancing mass pre-cryoablation. In summary, breast cancer cryoablation requires a multidisciplinary approach to the diagnosis, pre-treatment planning, and follow-up of a cryoablation patient. This multidisciplinary approach has a direct impact on the short-term and long-term success of the cryoablation procedure. A multidisciplinary approach should be utilized regardless of who performs the procedure, either a surgeon or radiologist working alone or with a partner. What I've shared with you in this presentation is just a small part of a much larger discussion, which you can read about in the publication that you can identify online. Thank you for your time.
Good morning. Thank you very much for the invitation. It's a real pleasure to be here once again at Breastmit to talk about the UK small trial, which, as many of you no doubt will be aware, is a trial of vacuum-assisted excision versus surgery for small screen-detected breast cancers. These are my disclosures. And just by way of a little bit of background, as everyone in the room will be aware, mammographic screening programs are associated with the detection of significant numbers of small breast cancers, which very often have favorable biology, low-grade, indolent tumors with a good prognosis. And historically, we've seen that the inception of mammographic screening and the detection of these small tumors has not resulted in an impact in the incidence of much larger invasive tumors, as shown on this figure here. Similarly, in fact, although I haven't shown the data, there is no impact on the incidence of metastatic disease either. And this has led to the description of the phenomenon that we all know as overdiagnosis. Now, I would contend that it's not actually overdiagnosis, it's simply diagnosis of small low-grade cancers. And the problem resulting from this is overtreatment of these patients with surgery, with radiotherapy, with endocrine therapy to achieve an excellent prognosis, but at a significant associated morbidity for our patients. And we know that estimates of overdiagnosis vary, but this is acknowledged globally to be a significant problem. And this is something that we are addressing in the UK SMALL trial, which is a phase 3 multi-center randomized trial addressing the question of whether vacuum-assisted excision under image control is an alternative to standard surgical approaches for the treatment of small, biologically favorable screen-detected breast cancers, also asking whether or not we can safely omit sentinel node biopsy in these low-risk patients, whether this approach is feasible and acceptable both to our patients and to clinicians, and whether it can be done with an acceptable requirement for a second re-excision procedure after VAE. SMALL is also asking what are the long-term local recurrence implications for breast cancer when it's treated in this way. So just as a brief reminder or a brief summary of the trial schema, SMALL is for patients with screen-detected cancers in the UK screening age group, which is 47 years and over, with a maximum diameter of 15 millimeters, unifocal tumours, grade 1 disease, and estrogen and progesterone receptors strongly positive and HER2 negative, thus aiming to pick up that population of patients which are most likely to represent overdiagnosed tumours. Patients should have negative axillary staging at the time of diagnosis with no previous diagnosis of ipsilateral disease. And patients in SMALL are randomized 2-to-1 in favor of VAE. Patients randomized to standard surgery will usually undergo a wide local excision together with a sentinel lymph node biopsy for surgical staging of the axilla, and then we'll have adjuvant radiotherapy and endocrine therapy according to local practice. Important to note in SMALL that radiotherapy and or endocrine therapy can be omitted in line with local treating clinician protocols. In patients where the randomization is to vacuum-assisted excision, the assessment of complete excision is radiological. It's not possible to assess margins on a pathological excision specimen, and therefore patients where it is considered by the operating radiologist, either at the time of the procedure or on post-procedure imaging, the lesion isn't fully excised. These patients will cross over and have standard surgery treatment to the breast. However, in patients where the radiologists feel the lesion is completely excised, then these patients will proceed to have standard radiotherapy and endocrine therapy according to local practice. We do mandate that they receive both of these treatments because we don't want to double de-escalate their therapy, but they can be given according to local guidance. So these may be partial or whole breast radiotherapy, for example, according to whatever is done in the local center. So we have two primary outcome measures in SMALL. The first is a randomized non-inferiority comparison of the requirement for a second procedure between the two arms. So we all know that following standard surgery, we'll send a wide local excision specimen for formal histopathological assessment. And in the UK, consistently, we see around 15 to 20% of patients have involved margins on histopathology, and that requires a second procedure. Following vacuum-assisted excision, as I've said to you, we can't pathologically assess the completeness of excision, so the assessment is radiological. And it's done by both intra-procedural imaging at the time of VAE and a post-procedure mammogram. We do provide through the trial a second opinion service, so if there is uncertainty locally about the completeness of excision, one of our trial radiologists will review the imaging and determine whether or not the lesion is completely excised. And if there is any residual lesion seen after the VAE, then these patients require a crossover to have standard surgical excision. The second primary outcome measure in SMALL is local recurrence rates following vacuum-assisted excision. Now, we know that these are going to be very low after standard surgery. In fact, if we look at the UK import low trial, we see local recurrence rates, local failure of about 1% at 5 years without any impact on survival. And we are asking the question is, can we achieve similar, comparable, acceptable local recurrence rates following vacuum-assisted excision where we don't undergo a formal margin assessment with biohistopathologists? I've said to you already that in VAE patients, we mandate radiotherapy and endocrine therapy, and patients will be followed up on an annual basis with for local recurrence or local failure. We have set a predefined boundary of an unacceptable local recurrence rate at 3 years, and the study is powered on this basis. What that means is that if the local recurrence rate exceeds 3% at 5 years, we will say that this is not acceptable. And this margin was set, or this predetermined boundary was set in conjunction with our patient advocates. We also have an early stopping rule in that if local recurrence exceeds 3% in any 1 year in the study, the Data Monitoring Committee will terminate the trial early on the grounds of patient safety. This is a single arm analysis of local recurrence rate because in this population where event rates are so low and local recurrence is so uncommon, we know that a randomized non-inferiority comparison of local recurrence between the two arms is not feasible on a numerical basis. It was going to require many thousands of patients and wasn't going to be a practical trial to carry out. So I know, and I presented here before, I know you'll all be wondering how we're getting on with SMALL, and I am pleased to report that recruitment continues to progress. We have a target sample size of 801 patients, and we're going to open up to 70 sites. Obviously, opening at the start of the pandemic in early 2020 was not conducive to a successful study, but we have persevered. We currently have 39 sites open, and as of mid-September, we have 325 patients recruited to the trial. So we're making good progress. We're projected to complete recruitment if we continue to open sites on schedule, complete recruitment in Q2 of 2025. So one of the things that I was asked to talk about today was acceptability, and I told you that that was one of the questions that we were asking in SMALL. And one of the ways we can assess whether or not this trial is acceptable is to look at what we call the screening log data, which allows us to keep track across the trial and across the country of how many patients are identified and deemed to be eligible for entry into the study. And this always lags a little bit behind recruitment, so these numbers don't quite tally with what I've shown you in the graph in the previous slide. But what you can see is that we've identified almost 2,000 patients in this time frame who have met the radiological criteria, so maximum tumor size of 15 millimeters, of whom 600 patients have been eligible. And what is very gratifying is to see that our research teams across the UK are approaching almost all the patients who are eligible. Inevitably, it's difficult to catch everyone, but most patients are being approached, and around just under half of the patients who are approached for entry into the study consent to take part, which is actually, I think, quite a good consent rate for a randomized trial in surgery. And if we look at the reasons that patients are deemed ineligible, it's not really surprising. Most patients are either not a grade 1 cancer, they're grade 2 or 3 on the diagnostic core, or else the ERP are strongly positive, and there are a range of other reasons as well. What I think is perhaps more interesting is to look at the reasons that patients decline to take part in the study, and we can see that some element of this is put down to patient choice, either patients not prepared to accept vacuum-assisted excision, not prepared to accept surgery, or patient choice other not specified. And I think a lot of that probably relates to not prepared to accept VAE or sentinel, or not prepared to omit sentinel node biopsy. Obviously, in the last 6 months or so, we've seen the SOUND trial being presented, which provides further evidence to support the omission of sentinel lymph node biopsy in low-risk populations. So it'll be very interesting, particularly once SOUND has been published, to see whether that impacts on this reason for declining the study. So that's patient acceptability, which we can get some handle on. We have done some audio recordings of patient consultations as well, and we will be doing some interviews with patients who have agreed to take part in the study, as well as those who've declined, but I don't have that data to hand as yet. However, we have done some work looking at clinician acceptability, because one of the things we have in SMALL is an inbuilt qualitative study, excuse me. And as part of that, we've undertaken some in-depth interviews with a number of recruiting staff as well as trial staff from around the UK. And I just want to present to you a very brief summary of what the clinicians have said. So in general, what you can see, I'm not going to read all the quotes out to you. The advantage of having it on your screen is that you can read these yourself. But what you can see is that there is fairly broad, widespread support for the need for the trial. It's a sensible trial, it's logical, it's a good trial, I can see the benefits, it's an interesting research question, and these are not just all quotes from me. You can see that there are a range of quotes from a number of people across the country. When we come to the design of the trial and the rationale for it, again, there was widespread support, and one of the issues that was raised was about the inability to histopathologically assess margins and the need for the radiologist to assess margins. And you can see that this actually is generally considered an acceptable approach by our trial radiologists. It's something that they've had to get used to, but you can see here that people are broadly happy with this. And similarly, when we talk about recruitment, we can see that across the UK, across the recruiting sites, people feel it's a good study to recruit to. Surgeons are good at identifying patients. Everyone's keen. There's buy-in across the team, and there's a palpable sense of enthusiasm. And I think that's true as we've gone on with the study, and I have spoken to the investigators across all our 39 sites. One thing that does always strike me is that there is a palpable enthusiasm for carrying out this trial. And really, finally, and germane to the whole thrust of this Breastmit meeting is that there is widespread support in this UK for de-escalation of treatment more broadly. And you can see here our interviewers have suggested that there are patients that might well escape with minimal or even no treatment at all, and that maybe we could de-escalate things further, and that some people, you can see there was enthusiasm to go beyond small, and we wanted to do this without radiotherapy. So there is an appetite, I think, in the UK for further de-escalation in this very good prognosis, low-risk patient group. And I think we will be planning to design further studies to build on small and some of our other de-escalation work that's been happening in the UK once small is approaching its conclusion. So just to conclude here, I think it's clear that minimally invasive treatment approaches for favorable prognosis disease are increasingly being looked at. And there are a number of studies, small is not the only minimally invasive study that is being done. There are trials looking at radiofrequency ablation, cryoablation, but these are largely single-arm cohort studies. And I quite strongly feel in this setting that we are going to need level 1 randomized evidence to change practice. Small hopefully will deliver that evidence. The data that we have to date suggests that the trial is acceptable to patients, suggests that vacuum-assisted excision is acceptable to patients, and our interview data from the qualitative studies suggests that there is widespread clinician support, not only for small, but for further de-escalation studies across the UK. So clearly I cannot deliver this study on my own, and I just want to extend my thanks to the entire trial management group who are listed here, as well as the two colleagues pictured, the late Professor Adele Francis, whose idea this originally was many years ago, and Maggie Wilcox, who was our patient advocate, who was originally involved in the design and development of the study. And I'll be very happy to take any questions after this talk. Thank you very much, and thank you again for the opportunity to talk to you.
Gostaria de parabenizar os apresentadores.
I would like to congratulate the speakers
Excelentes apresentações.
and excellent presentations, by the way, all of them. And now I will invite our speakers to ask questions and also to make remarks for our international speakers. I'd like to first invite Dr. Bertha Andrade Coelho. Dr. Coelho has a PhD in mastology, is a professor in the University Center, and she is a member of the board of the Brazilian Society of Mastology, Minas Gerais chapter. Our second debater is Dr. Roberto Giordano. He is a mastologist, member of the Brazilian Association of Mastology, member of the image department of the Brazilian Society of Mastology, and has a title of specialist. And also I invite our third debater, who is Dr. Shelley Hwang, who will replace Dr. van Duijnhoven. Dr. Wesley is a pathologist and expert in breast pathology of the Netherlands Cancer Institute. Dr. Coelho, please, you can start with your remarks. Thank you very much, Carol. Thank you very much, everyone, for the time, for being here with us. Dr. McIntosh, Dr. Holmes, Dr. Wesley. For us, it is a great honor to have you here with us today. I would like to start asking Dr. Wesley about the LORD study and the patients that decided for remaining in follow-up, the active surveillance, that is. Because actually when the person was asked about the decision to remain in the other arm, most of them preferred to be in the surveillance arm. I'd like to know if you control the procedures that are made if the vacuum-assisted biopsy or vacuum-assisted excision, and the patients submitted to the vacuum-assisted excision, they chose the active surveillance.
Hello. Good morning, good afternoon, wherever you are in Brazil. This is good evening here. So I tried to translate the translate modus, but it didn't work. So and my Portuguese is not really well developed. So how can I find the translation modes?
It's down.
Maybe I can try if
Bertha, can you
I'd
ask the
like to
question in
know.
English, please?
I'll try.
So-
I'll try.
Sorry?
Professor, what my question was, if the people who choose to be at the active surveillance group, they were more likely to have had vacuum-assisted excision and the whole lesion excised versus people who only had VAB.
Yeah, thank you for your question. Most women, you know, they get a vacuum-assisted biopsy, but there is definitely DCIS left, or at least the area where the calcification is, so to speak. So only for, you know, we know that, of course, there are very small areas with calcifications that you don't see calcifications after the biopsy. But by far the majority, there are calcifications in the segmental distribution present there as well. Does that answer your question?
I don't know. It was like when you have shown in imaging that the lesion was completely excised and the patient has this information, if she's more comfortable to choose to the active surveillance group. If you are controlling for this specific.
Yeah, the fact is we cannot be certain whether you remove the complete DCS lesion because, you know, the calcifications, that's something that's associated with the DCIS, but the calcification, new calcification may occur over time once the secretions become, you know, I would say dehydrated in a way. So you never can tell the patients we removed it completely by the vacuum-assisted biopsy. So we, as far as we know now, we don't see a trend that women for which the calcifications present are completely removed by the biopsy are more likely to opt for active surveillance. These days, about from 4 women, 3 opt for active surveillance and 1 is opting for conventional treatment. So that is quite impressive. And it has changed from a 1-to-1 ratio 3 years ago to a 3-to-1 ratio right now in the Netherlands. So the awareness that DCS doesn't need to be treated in many instances, and once you get outgrowth into invasive breast cancer, or that you see a mass appearing in your annual mammography, that you are really on time because the lesion will be small, it will not impact your life expectancy, and you can remove it by local treatment alone and not by systemic treatment. You don't need systemic treatment then. So that is, yeah, both healthcare providers as well as the women confronted with diagnosis of what we consider low-risk DCS feel comfortable with this.
Okay, thank you a lot. And the other thing I was wondering is when you separate the 2 groups in your recent publication, most of the standard treatment group had higher level of education, but their tolerance to uncertainty was similar. How do you explain these results now?
Well, we do not have a clear explanation for this. In general, women, there are differences in education in the Netherlands, of course, but the women that are better or are educated at a higher level, in general, they participate in trials more often. and that has to do with the information that you have to read, and also the communication between doctors, nurses on one side versus the patients involved, etc. So there is there's also, for many other trials, you see way more participants in trials from higher educated people than lower educated people or underprivileged people. The other thing is that the screening participation is higher in higher educated patients as well. So they and also women with less comorbidity, they attend the population breast cancer screening way more often. In the Netherlands, you have these buses. These buses come to town, and you have to climb 8 steps, so to speak. So if you come there with a wheelchair or whatever, then there is a hurdle to participate in screening. And there's also what we call a healthy cohort effect, that for screen detected DCS, you will find it more often among higher or healthier people. And why there is not so much a difference in cancerury. That's something that we still have to analyze. We don't know yet why.
Okay, thank you a lot, Professor.
Thank you.
Carol, thank you. I'd like to ask you, Professor McIntosh, specifically, Doctor, what are the vacuum-assisted excision protocol of your study group, and how do you deal with the margin conversation with the patients, and if it's an issue, and how is it working?
So those are great questions. We decided at the outset of the trial that we were going to be very pragmatic about how we allowed radiologists to carry out the VAE procedures. So we didn't stipulate, we didn't protocolize how we asked people to do VAE. They're allowed to do it as per their normal practice. So I know that some of the radiologists in the trial are doing removing the lesion and then taking what you might describe as cavity shaves with a second round of shavings. Some are not. The vast majority of them are being done in under ultrasound guidance in real time, so you can actually assess the completeness of excision on the ultrasound scan during the procedure, by and large, because you can see the lesion disappearing. You're quite correct. We can't have a formal histopathological assessment of margins, and patients are made aware of that in the trial literature when they're being offered the opportunity to participate. We haven't found that to be a barrier to recruitment. We know that assessment of margins, and Shelley will probably back me up when I say pathological assessment of margins is perhaps slightly more of a dark art than we sometimes think it to be. It's not always a clear-cut, easy thing for the pathologist to comment on. So we there you are. So we are happy with the radiological determination of the completeness of assessment, because of course what matters is not whether there are 1 or 2 cells left behind. What matters is the clinical significance of those. And in small, all these patients will have radiotherapy to the breast, and they will have endocrine therapy in this trial. And most patients are, I think, comfortable with that combination of things.
Okay, thank you. When we see your lectures and what we feel when we read the results you're already having, it seems like in the future, when minimally invasive procedures will be the standard of care, maybe it's more the opposite. The difficulty will be to tell a patient that she's not suitable for a minimally invasive procedure, and she will have to go on a standard procedure, surgical procedure.
So I think we know we've actually been doing a bit of work in the UK recently and internationally, asking patients which elements of their therapy they might prefer to de-escalate. which has been really quite interesting. And what we found is that there are a range. There is no doubt that some patients wish to de-escalate surgery, other patients wish to de-escalate radiotherapy, some patients would prefer to omit endocrine therapy if it was safe to choose one of these modalities to treat. So I think what we need is a broad evidence base to support different treatment de-escalations, because just as no two tumors are the same, so no two patients are the same, and patients will have different preferences as to how they want to proceed with their treatment.
Obrigada,
Doctor, thank you a
Bertha.
lot. And now I'll leave
Obrigada,
Dr.
Bertha.
Holmes to
Thank you.
Roberto.
Roberto, gostaria de fazer suas considerações.
Dr. Roberto, would you like to make your remarks? Please. Roberto?
Perdemos o Roberto.
Did we lose him?
Bertha, então pode fazer alguma...
No, I'm
apareceu.
here. I'm here.
Roberto,
Oh,
pode
there
fazer
you
suas
are.
considerações.
Okay, Roberto, please, the floor is yours. Well, Carol, thank you very much. First of all, I'd like to thank for the invitation. I'm happy to be here. There's a panel discussion, this high-level panel discussion on the scaling, de-escalation of breast cancer. I'd like to start asking Dr. Holmes. Dr. Holmes, he's speaking in English.
Article explaining the correlation for the other medical professionals. So the first thing that I would like to ask you, what are the issues that you find after you do the correlation in your patients, in your office? I mean, you find issues on the follow-up with the oncologist, with the radiologist, with the radiotherapist. What are the issues that you find after the collaboration in your own practice in the United States?
Thank you for the question, and good day, everyone. We find issues with all of the above, which is the reason that I wrote the paper. For the most part, people are unfamiliar with cryoablation, so they don't know how to fit it in the treatment paradigm. They don't know how it aligns with radiotherapy. They don't necessarily know how to utilize systemic therapy in the context of a patient treated without tumor removal. They don't know how to interpret post-treatment imaging studies. And so the purpose of the paper was to provide everyone with a common base of knowledge, to understand that cryoablation can simply be used as a substitute for lumpectomy, but that all of the other things apply. Systemic therapy would still apply, lymph node evaluation would potentially still apply, radiotherapy would still apply. The same principles that we apply to patients that have had lumpectomy or in case of VAE, for example. Radiology is a particular challenge because most providers aren't familiar, most radiologists aren't used to looking at post-ablation imaging studies and interpreting them. In the paper, I made a comment that when we first started to do, when lumpectomy was first performed, there was a similar learning curve with radiologists having to learn how to interpret breasts that were not removed, breasts that had been treated with surgery, breasts that had been treated with radiotherapy. There was a need for a learning curve for them to understand the common features that are developed after those interventions. In the same way, they must also learn how to interpret a post-cryoablation mammogram and ultrasound MRI. I included in the paper examples of what one should expect to see, but the way that we most commonly manage it is that we ask patients, if they can, to return to our facility or one of our associated facilities to have their initial set of imaging studies performed at the 6-month time point post-ablation. And then once that's read by an expert, it's much easier for a subsequent radiologist to compare future imaging studies to that one. So because they have now a new baseline. So that's how we manage it. But as I said, all specialties have a problem with it initially, but it's like most things, it's a learning curve and they get better over time.
Okay, great for answer. So another thing is we don't have, like you said, we don't have another gold standard research with cryoablation treating breast cancer, but we have also a very strong data from YST trial, right? I mean, 40% of patients having radiotherapy, and we still have 2% of local recurrence. So It's very strong data. So in your opinion, you have this data has to push doctors as breast surgeons to start do more collaboration around the world, because I know that every country has their own issues of starting to do their ablation on breast cancer. So you think it's enough to encourage breast surgeons to start doing more collaboration procedures or not?
I think we need more data. I mean, I think that, you know, patients fall on a spectrum, and just as you have patients that are great candidates for VAE, there are also patients that are great candidates for cryoablation. Small lesions, unifocal, well seen by ultrasound, mammogram ultrasound. They're the best candidates for lumpectomy. They're the best candidates for VAE, for example. They're the best candidate for cryoablation. So you have patients that fall into that category and would be the easiest ones to treat. There are also, you know, in the case of ICE3, older patients with low-grade tumors. So you can find a place to start. So, you know, there'll be some surgeons who will be more aggressive, enthusiastic, some who will be reluctant. And for the reluctant ones, you start with the easiest, you know, problems. For the ones that are more aggressive, you can expand the options, both larger lesions, younger patients, different biology. And so I think, you know, whether it's in the context of a clinical trial or if you're doing it outside of a trial, the team has to find the subset of patients that they're most comfortable treating. And then over time, you know, in my experience, you'll find yourself treating, you know, larger tumors with different biologies, different age patients, because, you know, we develop a base of experience to give us the confidence that we can treat, you know, any patient or many patients, a larger number of patients with more complicated, complex, you know, tumors.
Great. So thank you. It was great to have you here. It's a pleasure for us, for our organizers. Thank you, Holmes.
Thank you.
I would like to thank you all for this great discussion. We had doctors from 25 countries watching us right now. So it's like a knowledge for de-escalation for the whole world. Now I would like to... Agora eu vou apresentar a próxima coordenadora de mesa. Infelizmente,
Now
temos que
I will
encerrar
present the
nossa
next panel
sessão.
coordinator. Unfortunately, we have to
A
end
próxima
this session.
coordenadora
Next, the coordinator of the
será a
next panel
doutora
will be Dr. Gabriela Ramos Alves. She is a breast surgeon and breast image expert with focus on minimally invasive procedures, and mastologist of the Mater Dei Healthcare Network and member of the National Committee of Medical Residency Programs in breast. And I'd like to thank